Well, good evening, everyone, and welcome to what I hope will be the first in a long series that we're calling GMS Live, Global Myopia Summit Live. And this is the first of what I think will be twice monthly presentations. Now, before I introduce our guests this evening, I'll give him a chance to disclosures, but I just want to draw your attention to the list of my disclosures. This is for the last 3 years, and obviously tonight we're hosted by Broadcast Media, and I do speak in and write in for them. They're the artist formerly known as Pentavision, in case you haven't gotten up to date with the acquisition and rebranding. Anyway, so we can do away with that slide. And it's my great pleasure to invite our very first inaugural, first-time primary guest, and that is Dr. Jeff Walline. So, Jeff, how are you doing?
I'm doing great. Thanks for having me. And I like being the first one. Once you're first, you can't be anything else. So
that's it. You know, it's like being in the Hall of Fame. They can never take that away from you.
That's right.
So, Jeff, you and I go back a long way. We were talking earlier and figure out that it was about 31 years ago that we were in the same optics class back in Berkeley. Different sides of the room, but
yeah.
We were there together along with a few other of your classmates when they showed up. So interesting times. So what do you got planned for this evening after you get done with this? You doing anything exciting?
I think the basketball game just started, so as soon as we're done here, I'll be going there.
So that's quite a walk.
Yeah, I'll be hoofing it pretty quickly.
Okay, well, hopefully you'll meet the second quarter, and hopefully it'll help you get over the disappointment of Saturday, but we won't go there.
Yeah, we don't.
So anyway, Jeff needs really no introduction, but I'll make a few comments anyway. So Jeff is now a distinguished professor at The Ohio State University. And if you haven't been following the news, he is also the interim dean, because the regular dean is now the interim provost. So everybody moves sort of one chair to the right, I think, when these things happen. So congratulations on your, first of all, being a distinguished professor, Jeff, and then also being interim dean. That's another nice string to your bow. Jeff is, of course, president-elect of the American Academy of Optometry, and he's also incredibly well known in the field of myopia because of a number of studies that he's done, some of which we may talk about this evening. So, Jeff, anything to say, like disclosures, before we begin?
I think that's a good idea. I really only have one disclosure to give, and that's that I'm on the medical advisory board for Myoptex. Otherwise, I'm free for the taking.
Okay, so yeah, people are now Googling Myoptec. I think it may have been on my disclosures as well, but if not, I need to update that. Anyway, so Jeff, you arrived at Ohio State about 25 years ago, maybe a little more, and sort of threw yourself into a number of things, but myopia. Did you think at that stage that myopia really mattered, or was it just something to study? And if not, when did you think that? What first convinced you that myopia mattered?
You know, I think I was convinced that myopia mattered well before then. It's probably at about the same time that most other optometrists decided that myopia mattered, and that's when I first was diagnosed with myopia and actually first corrected for myopia. It's about the time I got my driver's license, and I remember driving after first getting my contact lenses and thinking, I didn't know you should be able to read the license plate in the car ahead of you. So I really realized that it mattered then, but that's uncorrected myopia that really matters. You know, to me, the question is, does the amount of myopia matter? when people are wearing vision correction, we're all seeing 20/20 basically for the most part. So does that matter? And it wasn't all that long ago that, I kind of got an inkling that it does matter. First of all, I think Catherine Rose published a paper that said that myopia does matter in terms of quality of life. High myopes have poor quality of life. But the study that really interested me was one by Pauline Cho, and it wasn't a primary outcome at all. But in that study, they fit high myopes, kids who had 6.5 diopters of myopia on average, with orthokeratology and tried to correct their vision, just 4 diopters of their myopia. So, to be honest, I thought it was a dumb study because the kids wore contact lenses at night and glasses during the day. And I thought, who's going to do that? But it turns out that reduction of refractive error meant a lot to the kids, at least anecdotally. They didn't survey this in a standardized way, but anecdotally, they said those kids love their vision. And it was primarily because they were able to wake up and see clearly that alarm clock just across the way. So that to me was a big indicator that the amount of myopia matters. And so based on that, we actually are in the midst of creating a survey to ask people about their uncorrected vision, because even though we're corrected most of the day, there are times when we can't be, or it's not convenient to be corrected. And I think that really matters to people. And so, that sort of gives me a hint that, yeah, myopia matters, and it's just sort of evolved from there.
Yeah, I mean, I personally, I quite like being a -2, but I'm glad I'm not a -6.
Mm-hmm.
I'm currently obsessing. I don't have much in the way of lens opacities, or there's nothing like being on stage with a bright light from the back of the auditorium to make you realize that, hey, your media is not what it used to be. But I'm already thinking about, okay, when I do have a cataract extraction, what do I want to be? Do I want to be an emmetrope? Do I want to be a -2? Do I want to be a -1? Do I want to do monovision? So these are the things that keep me awake at night.
Yeah,
So,
there are benefits to myopia as well as the downside. So
yeah, and just Jonas was pointing out that it actually reduces your risk of age-related macular degeneration a little bit, and also of maybe diabetic retinopathy. So there's swings and roundabouts, but certainly the data show that on the overall, it can be less than ideal.
Yeah.
So let me follow up with that question. So, 25 years ago, you started the CLAMP study where you compared myopia progression with rigid lenses and soft lenses. That was sort of where your myopia journey, your academic empire began. What's changed over the last 25 years in the way in which you sort of view myopia?
Everything. Back at that time, I used to give lectures, and I'd be the only lecturer at the meeting, and 6 people would show up. And so I was angry that nobody was interested in myopia. Today, I'm one of 6 lectures at a meeting. Each one of them has 200, and I'm just as angry that other people are involved in myopia. So I don't think I can ever be quite satisfied, to be perfectly honest. But there's been so many scientific advances related to myopia control. At the time that I did the study, there really wasn't anything that had been shown to provide meaningful myopia control in a systematic manner with a well-done study. And the one well-done study that we did with gas permeable lenses showed that they don't really work. So now we have options available, and lots of options available. And we even have options available for those myopes with astigmatism. We have options available for people who don't want to wear contact lenses, people who don't want drops. We've got all sorts of options that we can provide to our patients. And they're available for you to get just down the street. So, I think sort of everything has changed, and I think we'll get to this probably a little bit later, but it's even changing the way we investigate some of these things.
Yeah. So from what you're saying, you're talking about the range of options that we have to slow myopia progression, to slow axillary elongation. There may be still some people out there that's like, what are you worried about? Why are you trying to slow myopia? Why is it's not a big deal? What do you say in response to that?
Yeah, exactly. I talk about the convenience. That's one thing that people really understand and is immediate. But we've also got to talk about the long-term consequences. So when you're 50, 60 years old, you're at higher, the more myopia you have, the higher risk you are for myopic maculopathy or permanent vision loss. And you're the one that found that for every diopter less myopic you are, you decrease your chances of myopic maculopathy by 40%. And I think that's a big number to take away. Now, those people will say, but that's a relative risk. That's not an absolute risk. On an absolute risk, it's still low. Why are you even worried about that? And I think it's because the stakes are so high. If you're talking about vision loss, that's something that is really important to people. And when you're talking about something that is high stakes as vision loss, then relative risks really are important. And so, I really truly believe that that's one of the main reasons that we ought to do it. But then, again, people don't want to think about their kids at age 50 or something like that. So I really talk about, it makes you a better candidate for refractive surgery if you have lower amounts of myopia. You have more options available to you. They're probably less costly in terms of spectacle wear, contact lenses that are available. So, I think there are lots of benefits to ultimately lowering the amount of myopia that people experience. Some that are immediate, and probably the biggest health concerns are long term.
Yeah, I mean, we'll talk about sort of healthcare later on, and the idea of doing something today that has a benefit 50 years down the road. Just two things. One is attendees. If you're watching live, feel free to enter a question into the question box if there's something you really want to ask Dr. Walline or even myself, but Jeff's available to answer questions. If you're watching this online in its recorded form, just think really hard about the question you wanted to have asked. Maybe it'll be asked on your behalf. The other thing, just as an editorial, Jeff, editorial comment, the issue of relative risk and absolute risk has come up, and I got challenged on that in Australia when I was speaking a couple of months ago. So I actually went back and looked at the actual numbers. And when you look at visual impairment at the age of 70, 75, the absolute risk is pretty big if you're a myope. And the numbers are sort of 10 to 20%. So lowering that risk is actually quite meaningful. So something perhaps we need to revisit. Yeah. So what should doctors be using to administer to children for myopia control? I mean, you probably have some favorites, but what are the options that you sort of tell people they should think about using?
Yeah, right now in the United States, I think we have three options. One is orthokeratology. One is what I broadly refer to as soft multifocal contact lenses. And the third one is low concentration atropine. I think that's what we have available right now. The rest of the world has special myopia control spectacles available to them, but we don't have those yet. And then the other things that we have potentially are ways to delay the onset of myopia. And we know that the later the onset of myopia, the less myopia you have as an adult. So if we can delay it, we might be able to ultimately make you less myopic. And the two things that we have available to us there are outdoor time. So kick those emmetropes outside so that they are less likely to become myopic, or low concentration atropine, which has been shown to actually delay the onset of myopia. So, I think those are the ways that we have available to us today. I think in terms of delaying the onset of myopia, there's been one well-done randomized clinical trial in Asia, but more needs to be done in that area. But I think there's a lot of promise. And then
sounds like that's something you're interested in there, Jeff. You got any plans in that area?
Yeah, we've got the donut study, the delaying the onset of nearsightedness until treatment study. We actually have a clinical trials planning grant right now. And so what we're trying to do is show reviewers that we can actually conduct a study like this. And so our goal is to determine if low concentration atropine can actually delay the onset of myopia. We are well underway to try and get to that point.
Yeah,
Um,
but you sort of said that you regard the evidence for using atropine to delay onset as being reasonable. I mean, obviously, it's only been done in Chinese kids in Hong Kong, but I mean, you and I know some people who have myopic. Oh, sorry, you and I know some high myopes or myopic optometrists have already got their pre-myopic kids on atropine. So, do you think there's any harm in doing that right now?
Absolutely not. And there's evidence to show that it works. So obviously, you'd be using it off label, but that's okay. The FDA does not tell doctors how to practice. It just tells companies how they can market their products. So it's okay to do things off label as long as there's some evidence to show that it might work, and that evidence exists. So I
Yeah,
think it's something people can be trying.
you nailed it there. That it's an important distinction between what a doctor is able to do and what a company is able to market.
Right.
Uh, we When I was on the FDA panel, my colleagues from the ophthalmology side would often joke that MD stood for may do. Anyway, but in terms of practice, again, myopia control is kind of a premium service, certainly given the things that you talked about there with multifocal soft lenses, ortho K. How What should a doctor do to make sure that everybody has access to the appropriate care?
No, that's one of the difficult things. It's right now it's not covered by insurance, so not everybody has access to this. Only the rich do, or those with more means. Um, But I think what we need to do as optometrists is educate everybody. You can't make assumptions about what people are able to do or are willing to do. So we have to educate absolutely everybody about it. That's one. Two is, you know, doctors can maybe for every premium fit that they do in terms of myopia control, maybe they can, and maybe for every 10 patients that they fit and put in the premium um, treatment for myopia control, maybe have one that they donate care for, something like that, so that it's available to everybody. The companies also quite often have um, programs where you can get treatments at lower cost or at no cost for every one that you purchase or every five that you purchase, something like that. And those could be used for those patients who can't afford it.
Mhm.
And we can look at what's the more affordable treatments and provide sort of a variety of treatments for our patients so that they can choose the ones that are closer to their range that they can afford a little bit better.
Yeah, I
It-
mean it's interesting that we live in a country where health disparities exist, and myopia control is just the latest in a long line
hmm,
uh, where you have these disparities.
yeah, absolutely. I mean, do you ever think insurance will cover myopia control?
Well, yeah, I mean, I think in its current incarnation, I think it's unlikely that insurance would cover the bulk of it. Could insurance pay a portion of it? Um, we don't know. I mean, but you know, I mean, again, if you are in private practice, you like anything that's a cash business rather than hooked to insurance. So that may or may not be an
Right.
attractive thing. Um, I know what you're going to say here because I heard you give the answer actually probably two academy meetings ago. But I'll ask the question anyway, and people can, again, if you want to chime in, submit a question. I'm not seeing any coming through, but feel free to go to the button there on the left and throw us a question. Where are we? There we go. Jacob's just issued a prompt. Yeah. So my question to you is, Jeff, and I think I know the answer. At least I know what you're going to say. Is myopia control the standard of care now in the US?
Let's see if I give the same answer.
Well, it's like, yeah, my question, my answer to some questions is, well, it depends who's asking me, or it depends who's paying me to answer it.
Right. um, you know, myopia control is evolving so rapidly that the answer almost does change. But basically, I think we're at a place where people who practice optometry at an advanced level, people who are doing most of the education, people who are on the forefront of the profession are practicing myopia control. I think there's a lot of optometrists who aren't necessarily there yet and aren't yet practicing to the full scope of practice, haven't learned about myopia control at this point. And so it's hard to say whether it is standard of care, but I think it's at the place where it is really close, if not there already, and we should be offering it to all of our patients. We should be educating them about the opportunities that are available to them, especially since as myopes, we have to correct them. And many of the treatment options that we have available for our patients treat or correct their myopic refractive error and also have the side benefit of slowing myopia progression. So yes, I really think we are right on the precipice of it being the standard of care. I can't say necessarily that it's there yet, but I think it's getting really close, and people really ought to start paying close attention to how we ought to be treating those young myopic patients today.
So you would say if somebody's not practicing myopia control in their setting right now, they need to be thinking about doing it in the future, or at least partnering with somebody who does.
That's exactly right. If they're seeing young myopic children, then they ought to know about this, or something that our profession lacks, and that's interprofessional referrals.
Yeah. And again, that's, yeah, I mean, we talk about duty of care, duty to inform. Sooner or later, if you're not offering it, you're probably going to have an angry mother to deal with somewhere down the road, or an angry patient
or an angry colleague.
Angry colleague. No, I mean, it's, I think the challenge with a steeply or a rapidly evolving field is, where are you on this steep curve?
Yeah.
And getting back to what is available. I mean, you mentioned soft lenses, low concentration atropine, and orthokeratology. 2 out of the 3 are off label right now.
Mm-hmm.
We don't have access to the state of the art spectacle technology that our friends in Canada do. What do you think is going to be the biggest rock that's going to fall in the pond in the next couple of years in terms of affecting the way people do practice and the number of people who are given myopia control options?
Yeah, I think if spectacles are ever approved in the US, I think that's going to have the biggest splash in terms of actually getting myopia control to people. Getting more options FDA approved, I think would be beneficial as well. And then if we get a low concentration atropine approved that we don't have to get from compounding pharmacies, because compounding pharmacies are sort of the wild, wild west. We can't always guarantee that our patients are getting what we expect them to be getting. I think that could make a difference as well. So, I think there's lots of things that could potentially happen to make a big difference. I think the biggest of those, though, will be spectacles for myopia control.
Yeah, I mean, as you said before, it's, I mean, with atropine, you got to prescribe it. You've got to monitor whether you're having success, but the kid still needs glasses. If the myopia control treatment is baked into the prescription, that's obviously going to be attractive. And anybody who has nervousness about putting kids on drops for many years or putting kids into contact lenses, you would probably say that's an unfounded concern. But spectacles will bring things, I think, a little bit more mainstream, as you suggest. So it's interesting, and there's a whole bunch of things that are various stages through FDA trials and processes. So it's going to be an interesting field to watch. Anything to add there?
No, I just think with the people have to keep educating themselves. Go to the continuing education lectures, read the literature, and that can, read the contact lens spectrum review, all these different publications that give you summaries of the information that's available, and then go find the source information and really learn what we need to know about the best ways to treat these young kids, because I think it is important.
So you've done trials on soft lenses versus rigid, soft lenses versus spectacles. You've done some case series looking at ortho K, looking at multifocal contact lenses. You've done this wonderful randomized clinical trial where you randomize kids to either a high ad, a medium ad, or a single vision contact lens. All of those studies involve an untreated group of children. Do you think that's something that's still ethical to do? And how comfortable would you feel about withholding treatment as part of a clinical trial now?
Right. There's the ethics that are involved. I completely agree there. We know something works, so why are we holding it from kids? That's difficult. The other problem or issue with, putting people in single vision glasses or contact lenses is that they can go down if they get randomly assigned to wear those, they can go down the street and get whatever, treatment option that they want. And so that makes it difficult also. The benefit, though, of doing that is that you can compare across trials, and we've got lots of trials out there that you always want to know, is this working as well as that, or you want to be able to compare. And if we start using a different control group, then comparisons will become much more difficult. So I think as a profession or as a group of research scientists, we need to figure out what is the next control group. A lot of people have just talked about retrospective cohort studies where we know what their typical eye growth is and what typical myopia progression is, and compare to those. We've talked about comparing to other myopia control treatments. So what's the gold standard, and comparing to that. So we have options available. If I were designing a myopia control study right now, I would. I'm obviously can argue both sides. I don't know exactly where I do on my next one that I started tomorrow, but I will tell you this: we are looking at, like I said, the clinical trial to delay the onset of myopia, and that is an untreated comparison group, because we aren't routinely treating the emmetropes yet. So that's a different story. That's a little easier for me to answer, but it's difficult to figure out what to do ultimately.
Well, it's a challenge for us as scientists, and it's a challenge for the regulatory bodies around the world as well. I mean, if you look at, let's take an example of glaucoma. The FDA, in evaluating a new glaucoma therapy, be it a shunt or a drop, they're not going to randomize people to no treatment. They're going to randomize to the current standard of care, whether it's a beta blocker or a prostaglandin analog or whatever. Likewise, if you look at anti-VEGF drugs for neovascular retinal disease, initially it was compared to, whatever it was, photodynamic therapy. But then as soon as the results came out for that first generation of drugs, that became the gold standard against which the next anti-VEGF drug was compared, and then the third generation was compared to the second. So we're not there, and I think from a regulatory perspective, the FDA is not there yet, but I think we may get there fairly soon, and looking at perhaps more innovative study design. So before we finish, Jeff, any messages, anything you want to throw back in my face, anything you want to say to the audience?
I think the audience that's here is probably practicing myopia control. That's why they're part of this, but they need to talk to their colleagues and to get them interested and knowledgeable about that particular thing as well. And we've got to continue educating ourselves. Just so people know, if you have questions, you can always send me an email. It's my last name .1@osu.edu. I'm happy to answer questions. I would rather answer questions and get people practicing to the highest standard and the correct standard as quickly as possible. So please feel free to ask questions.
That's good advice. So, Jeff, thank you very much for being number one, our very first, and always our first in this what will hopefully be a long series. I want to thank those of you who've joined us live today. And I want to prompt everybody, whether you're watching live or watching reruns on the interwebs, a recorded version of this. The next GMS Live will be on December 13th. That's again a Tuesday. The wonderful and brilliant Ashley Wallace Tucker will be hosting, and she will have two guests, Andrew Newkirk, I think I butchered his name, and Jennifer Lyerly. And I think, again, that will be a very lively session. So I would encourage you to attend there. And if you've enjoyed this, tell your friends. And hopefully we'll see you online again or at a meeting very soon. So thank you very much.
Thank you, Mark.